My talk is going to be about kidney cancer surgery, but I figured since I was the first person talking, I'm also going to give a little bit of a brief overview just about kidneys and kidney cancer in general, so we're all on the same page for the day. We're all here to talk about kidney cancer, but we may or may not know what the kidneys actually are, or where they are, or what they do. And the kidneys are paired organs, meaning the body is pretty symmetric by design, and we have two kidneys in our body, one on the right and one on the left. And what the kidneys actually do is filter waste products and toxins out of the blood and put them in the urine, and so it's kind of a two-part process. It's a working part, which is the actual meat of the kidney, which you can see here if the pointer's working, and then it's a plumbing part, which is this part, which takes the urine down to the bladder. Unfortunately, like many other organs in our bodies, kidneys can form tumors, and a lot of these tumors are cancers. And this is what a kidney cancer can look like in a kidney when we take it out. But not all renal masses that we see are kidney cancers, and that's one of the fine arts of walking patients through this process when we see them in the office. And so about 85% of all patients with a mass will be a cancer, but some of these tumors are benign, and part of our job is to figure that out as best we can. Size matters to a certain extent, meaning the bigger a mass in the kidney is, the more likely it is to be a kidney cancer. And so masses that are about 1 centimeter in size have a 50% chance of being a kidney cancer. And when you start getting up into the 3 to 4 centimeter size, you're upwards of an 80 to 90% chance of having a kidney cancer. The incidence of kidney cancer has been increasing in the United States pretty steadily since the 1970s. And this is mostly due to increased use of axial imaging, meaning CAT scans and MRIs. Nowadays, if you go into the emergency room with abdominal pain or back pain, one of the initial things that'll happen is you'll get cross-sectional imaging, and so we're finding a lot more of these small renal masses just incidentally or by luck, and that's continued to increase over the past decades, about 1% per year. Kidney cancer demographics in this day and age: it's the 6th most common cancer in men and the 7th most common in women. It's most frequently diagnosed between 55 and 74, and about 14,000 people in the U.S. die from this disease. Most of these, like I said, are by chance. We'll find them incidentally. The majority are asymptomatic, but about 10% of people will have a symptomatic kidney cancer, either with blood in their urine or flank pain. And bone pains and cough and generally not feeling well can be signs of advanced kidney cancer. Size is important. I tell my patients when I think about renal masses, it's kind of the same way we think about real estate, meaning size and location is really important on how we manage these tumors. And just to put it in perspective, a lot of people, when we grow up in this country, we think about things in inches, but when we think about things surgically, we talk about centimeters, and that can be hard for people to understand. And so, if you hear a tumor is 7 centimeters, you can kind of think of a baseball. A baseball is about 7 centimeters. A golf ball is about 4 centimeters. And at least by this slide, a pea is about 1 centimeter, although I would argue a pea is kind of smaller than 1 centimeter. But that gives you some perspective about size of tumors in relation to things that we think about every day. These are the basic stages of localized kidney cancer. When we think about T1, confined to the kidney, less than 7 centimeters, so less than the size of a baseball. T2 is greater than 7 centimeters, so bigger than a baseball, but still confined to the kidney. T3 is when we start thinking about tumors that are growing outside of the parenchyma or the working aspect of the kidney, either into the renal vein or into the fat around the kidney. And T4 is into the adrenal gland. And just to point out, T stage is different than global stage. A lot of patients will get the confused, and appropriately so, because we talk about stage 1, 2, 3, and 4. But when we're talking about T stage, we're really just talking about where this tumor is in relation to the kidney and to structures around the kidney. This is the NM, or the nodes and metastasis. So kidney cancer, like a lot of cancers, can go anywhere. But predictably, it does go to the lymph nodes around the kidney. And then some of the more common sites when it goes elsewhere, lung is very common, soft tissue around the kidney, and then bone and liver is very common as well. And obviously, where you're starting from a TNM standpoint dictates a lot of how we think about patients surgically and systemically from a treatment standpoint. So this is just the stage in words. You saw it in pictures, and because of this, because of the amount of imaging we're doing, we're seeing a lot of patients present here with stage 1 kidney cancer in this day and age. But we still see about 25% of patients, presenting with more advanced stages. Again, we've seen a stage migration over time to smaller tumors, mostly related to imaging. Survival is mostly related to stage, just like many other cancers. And a lot of these small organ-confined kidney cancers that we pick up on incidental imaging, very curable. Even when tumors are relatively big and confined to the kidney, still very curable with surgery. When we start talking about tumors going out into the fat around the kidney, into the vena cava or other tissues, that's where things can be a little bit more challenging for us. So kidney cancer treatment in general, it's very complex decision making. Some of it, has to do with cancer stage, but it also has to do with your general health. Are you up for surgery? Are you not? Can you tolerate systemic treatment? And obviously patient preference is a big part of this. For small renal masses, surgery certainly is an option. So is active surveillance, meaning just following some of these smaller tumors, because not all of these tumors are destined to either grow or go elsewhere. We do use thermal ablation, meaning instead of surgery, using an energy source to either freeze or cook tumors, particularly for tumors that are less than 3 centimeters is where it works the best. We can use targeted systemic therapy, immunotherapy, and as discussed a little bit earlier, clinical trials. But what I'm going to talk a lot about today is surgery, and it's really the main treatment for the majority of kidney cancers, with the goal of removing tumor and, when feasible, preserving renal function, and we'll talk a little bit about that. These are some of the guidelines we use when we think about surgery for kidney cancer. And again, I think about these tumors when I'm thinking about organ preservation, more about size and location. You can have a small tumor right smack in the middle of the kidney, and that can make nephron-sparing surgery challenging. And you can have a big tumor kind of on the periphery of the kidney, and that can actually be pretty simple from a sparing the kidney standpoint. So a lot of factors go into how we think about these tumors. Whenever feasible, we try to preserve kidney, but there are times where we have to take a whole kidney out. So the goals for kidney cancer surgery, how we think about it, obviously number one is oncologic outcomes. When we think about kidney tumors in general, from a surgical perspective, the first goal is cure, and so we have to keep that in mind. Second goal is renal functional outcomes. Whenever feasible, we want to preserve kidney. There's lots of studies that show that the better your renal function is over the long term, the less morbidity, the less likely you are to have other issues, cardiovascular issues. And then third is decreased morbidity. And so what we're talking about here is minimally invasive surgery. Whenever feasible, if we can approach these types of tumors laparoscopically or robotically, we do. And the benefit of that is getting patients out of the hospital quicker, feeling better quicker. But there are times where we still do open surgeries, and we'll talk a little bit about that today as well. So my experience, I always tell people, I would like to think I'm pretty unbiased from how I approach these types of tumors. I went to Temple Medical School. I'm pretty much a Philadelphia or a Northeast person the whole way. I trained at Penn for residency. I did leave the city for 2 years when I went to Hopkins for a fellowship, but came right back after that. And so I'm trained in all aspects of kidney surgery, whether it's open, laparoscopic, or robot. And so, when I think about these things, the approach becomes less important than what's going to be best for the patient, with the three things we talked about in mind earlier, meaning how are we best going to cure the patient, how are we going to best preserve renal function, and then how are we going to limit morbidity. And all three of these types of surgeries have a role, depending on the clinical situation. For small kidney tumors, robotic surgery has become very popular, and most notably in the arena of partial nephrectomy. And the reason why robotic surgery has really helped us with partial nephrectomy is because laparoscopic surgery, meaning when you're actually holding the instruments, is a pretty challenging operation from a partial nephrectomy standpoint, because it can be hard to suture the kidney back together laparoscopically, particularly with the time constraints that you're sometimes under. Meaning when we do these surgeries, we are often temporarily cutting off the blood supply to the kidney to minimize blood loss, but also so we can see the tumor when we're cutting it out. And so one of the critical aspects of doing that is getting that clamp off the renal artery as fast as possible. And robotic surgery has helped us with that. And so, when you look at the numbers for minimally invasive partial nephrectomy over the last decade, they've risen dramatically, and that's mostly because robotic surgery has allowed more permeation of this technology. We've looked at the robotic surgery here in national databases, and when you compare robotic partial nephrectomy to open partial nephrectomy, they're very equivalent from oncologic and functional outcomes, meaning there's nothing about robotic surgery that makes it better or worse from a cure standpoint as long as it's done appropriately. Same with nephron preservation. But people who can have minimally invasive surgeries tend to have less blood loss, reduced pain and discomfort. They tend to get out of the hospital quicker. They tend to recover quicker, meaning back to work quicker, and smaller incisions from a cosmetic standpoint. So there is some value in minimally invasive surgery over the short term for patients just getting back to life. This is kind of what it looks like from an outside perspective, meaning the surgeon's actually not is about 5 or 10 feet away from the patient looking into a robotic console. And the beauty is these robotic instruments are wristed, and they have multiple degrees of freedom, unlike a rigid laparoscopic instrument. And so we're able to make complex maneuvers in very small places in the body, and that's really the benefit of robotic surgery. This is what it typically looks like in the operating room, meaning this is the robot, and you typically have a bedside assistant, but the surgeon's actually, not at the bedside, because they're operating the robot from a console. And these are the small incisions we make, and the robot docks to here, and the robotic instrumentation goes through these ports, which are very similar to laparoscopic ports. This is what it looks like in real time. This is a kidney tumor of a patient, and I tend to do these in what's called a transperitoneal approach, meaning the first part of the operation is moving the GI tract over to be able to get to the kidney. This is dissection of the blood vessels of the kidney again, so we're able to clamp the vessels if needed. I don't operate this fast, by the way. This is people have accused me of being fast, but I'm not that fast. This is a kidney tumor, and we can use ultrasound right in the OR to confirm and know the depth. This is the bulldog clamp going on the artery, and then this is the actual partial nephrectomy, and you can see the renal vein is open, so you will see some venous bleeding during this, but we can do this in a relatively bloodless field with clamping of the vessels, and you can see it very precisely with the robotic arms and the instrumentation. And so the tumor, we cut it out. I tend to send margins from the base here, although you don't necessarily have to. And then again, one of the benefits of robotic surgery is the ability to very quickly and pretty simply suture the kidney. This is a little bit of an older video for me, meaning I don't quite do it like this anymore, where these are interrupted sutures. I tend to do it in one suture now because, again, it's quicker and easier. These are just Surgicel bolsters to help, if there is any bleeding after, to minimize any postoperative bleeding. Again, this is just a speed thing, these clips, so we don't have to necessarily tie. And then the bulldog comes up, kidneys breathing again, and we, that's a robotic partial nephrectomy in a nutshell. Some of the other things that we're doing here at Penn to enhance our ability to take care of patients surgically from a kidney cancer standpoint is in 2015 we opened up our our Center for Precision Surgery, or Intraoperative Molecular Imaging Program, and this was a major initiative at Penn, not only in kidney cancer, but across the board with all cancers here. And what we're doing is using intraoperative fluorescent molecules to help us find cancers in the OR, and we can do this both open, laparoscopically, and robotically with near-infrared imaging. One of the benefits of the robot is it actually has a near-infrared scope built into it, so we didn't have to really change much from a technology standpoint. And here, not only have we done this in kidney cancers here at Penn, this is a kidney tumor lit up with near-infrared imaging, but we've done it in prostate cancer and testicular cancer as well, and we're continuing to push the envelope on intraoperative molecular imaging. You may hear about Firefly out in many places, and you can use this same technology to look at blood flow, but we use it a little bit differently here, meaning instead of giving the near-infrared or the infrared dye in the OR, we give it about 24 hours before, and it has a tendency to collect in tumors. And this is what a tumor would look like with white light, but you tend to be able to see these things very well with near-infrared imaging in the OR. It can help with margin status for partial nephrectomy. It can help for looking for lymph nodes and things like that. Doesn't work in everyone. For kidney cancers, they tend to have a lot of folate receptor alpha cells in them, and that's one of the molecules we target for kidney cancer specifically. For bigger tumors, like we talked about, some people are not candidates for partial nephrectomy, and you can see here this tumor, in order to remove it, there wouldn't be very much meaningful kidney remaining, which is here, or we probably wouldn't be able to spare the blood supply, and so we will do radical nephrectomies. The vast majority of these are done laparoscopically, meaning without robotic assistance, because this is a more straightforward technical operation. But I do some robotic nephrectomies, typically when they're larger tumors or more complex tumors, because the robot does have a couple extra arms, and so I do feel like there is some benefit sometimes from a retraction standpoint. But you can see even with a relatively big tumor, we're able to make these incisions pretty small at the end, even when we're taking the kidney out. There are patients who have not only kidney tumors, but kidney tumors growing into the vascular supply of their kidney. Kidney cancers tend to like blood vessels. They tend to make blood vessels. And so, about 15% of people that we see with kidney cancers will have some degree of vascular involvement. These are the most complex types of surgical procedures for patients with kidney cancer. And you can see here, these can run the gamut from just being in the renal vein to actually going up the inferior vena cava, which is the major vein in people's body, all the way up to the heart. And one of the things that I think I'm most proud of at Penn is we've established a multidisciplinary venous involvement team here from a kidney cancer standpoint. This is something we put together when I came back in 2009. And I think it's critically important for these types of cases. These are different kind of kidney cancer surgeries. When you start talking about opening up blood vessels or operating on the heart, the risk of these surgeries is much higher than the average type of surgery. And so we put this team together when I came back in the interest of really trying to decrease the morbidity of this operation, decrease the risk of this operation, and I think we've made substantial improvements here. From a personal standpoint, it's been really fun for me to do this because all of these guys you see on these slides I actually trained with. They're all Penn trained. Ben Jackson, who's a vascular surgeon, was a year ahead of me in residency. Pavan Lurie, who's a cardiac surgeon, was 2 years ahead of me in residency, and Rob Rosens, who's a liver surgeon, was 1 year behind me in residency. So we all kind of grew up together here, and we do these cases together here, and it's been very gratifying, and people have done very well. The reason we have this team is you really need an integrated approach for this type of procedure, meaning I do the kidney part. If we need vascular involvement, Ben comes in and takes the tumor out of the vena cava. Often we'll replace it with material or graft it if necessary, if we actually have to remove part of the vena cava. Sometimes these tumors in the vena cava are growing up through the liver, And in an effort to avoid cardiopulmonary bypass, we have a liver surgeon come in and mobilize the whole right side of the liver so we can do these without getting into the chest. But occasionally these are growing all the way up essentially into the heart. And that's where our cardiac team comes in, and those are the cases we do on cardiopulmonary bypass. And so, whenever we do these types of cases, we're all kind of thinking about it together and doing it together. And I think it's been a major advantage for us here at Penn. There are occasions where we still take kidneys out in the setting of metastatic disease. The paradigm has shifted on this a lot over the last several years because systemic therapy is working so well for patients. But we do take out big tumors in patients with kidney cancer elsewhere, sometimes from a symptomatic standpoint, often in people who are doing very well on systemic therapy, but maybe didn't have as great a response in the primary. And these are tumors, again, can be big, can be challenging. So we do them all different ways, meaning open, robotically, or laparoscopically, depending on the approach. So surgery, in summary, is really critical to patients with kidney tumors and kidney cancers. Most of these small tumors will manage minimally invasively. They're highly curable, so the goal is not only cure, but nephron preservation and decrease morbidity. Some larger tumors we still do minimally invasively, and occasionally partial nephrectomy, but often radical nephrectomy. Open radical nephrectomy, particularly with thrombectomy, they're complex. They require a multidisciplinary approach. And as I said, cytoreductive nephrectomy we still utilize in certain situations. So that's the University of Pennsylvania. I'll have to change this slide soon with the new hospital going up, but thank you very much.